Welcome. Thank you, Dr. Renaer and Dr. Agma, for joining us today for our discussion of BIS monitoring and perioperative outcomes and whether or not BIS monitoring makes any difference. I'm going to start out with a broad question for both of you. I would like to know, for which patients undergoing general anesthesia is intraoperative EEG monitoring indicated?
Good morning, Christina. Good morning, Dr. Agma. Well, I'm glad you asked me that question, and quite frankly, I'm surprised that we as a specialty have embraced monitoring other organ systems like the heart and the lungs, but haven't embraced monitoring the brain. As way back as 1937 it was proposed, and the answer to your question is every surgical patient should have brain monitoring in 2014.
All right, and Dr. Agma, what's your response to Dr. Renaer? In your opinion, for which patients undergoing general anesthesia is intraoperative brain monitoring indicated?
Yeah, I'm glad you asked me that question, Christina. I think that the answer to that is that ideally we would like to monitor everybody's brain. So that's the wrong question. The question is why we don't do it yet. And the answer is because the brain monitors that we currently have are not sufficiently scientifically based to give us precise information. It is necessary for us to refine the monitors so that we have monitors based on neurobiology, and then I will say every patient, but not yet.
All right, Dr. Renaer, moving on back to you, I want to discuss some more specific outcomes and the role of BIS monitoring or other processed EEG monitoring in those outcomes. So let's start out. I'm going to ask, does intraoperative EEG monitoring usage result in decreased intraoperative awareness?
Absolutely. There have been several randomized controlled trials that have convincingly shown a decrease in intraoperative awareness with processed EEG monitoring. And a false dichotomy has been set up between EEG monitoring and anesthetic concentration. Use them both. A combination will decrease intraoperative awareness to negligible occurrences. This is a silly argument. Of course it will decrease awareness.
Okay. And Dr. Agma, what do you think? Does intraoperative EEG monitoring decrease awareness?
Of course, that's a very topical question. And the answer is it can. It can if you are using it against no protocol or bad practice. But the evidence now is overwhelming that if you set an alert for a low volatile anesthetic concentration, it will be as effective or not superior to the current generation of brain monitors, which, as I've said, are imperfect. For total intravenous anesthesia, the evidence is more compelling for a brain monitor, but that hasn't been compared against target controlled infusion. And until that's done, the jury is out. So the answer is we do not know in total intravenous anesthesia, and we do know with a volatile agent. The answer is categorically no.
Okay. Dr. Renaer, back to you. Next question. Does intraoperative brain monitoring reduce anesthesia dosing, and does it improve postoperative recovery?
Yes, of course. Christina, I'm surprised that you even have to ask me those questions. There have been studies on that for almost 2 decades now. And when you put a brain monitor on a patient, you can, with much confidence, decrease anesthetic concentration, especially towards the end of the case, and patients wake up better, they spend less time in the recovery area, they have less nausea and vomiting, and you've used much less anesthetics during the case. It is not even a debate anymore. The answer is yes.
All right, and Dr. Agma, do you agree?
No, Christina, that's not true. It's the small efficacy trials where people have been highly motivated to decrease anesthesia dose. They're not blinded. Obviously, they decrease the amount they give. Patients wake up better. But in the very large effectiveness trials with tens of thousands of patients, there is no difference in the amount of anesthetic that's administered or in postoperative recovery characteristics. And it's not surprising. I'll tell you why. Because the current generation of brain monitors do not allow fine titration of anesthesia. There is a plateau over a concentration of anesthetics, and volatile anesthetics, for example. The index is flat. So you can't titrate with these brain monitors, and it will not allow you to finely tune your anesthetic. So no big surprise, right?
Okay, moving on again. Next point of discussion, does intraoperative brain monitoring decrease postoperative delirium?
That's a great question. And there have been detractors about brain monitoring, but now there are 4 randomized controlled trials, 3 of which have shown a decreased incidence in postoperative delirium, which is not surprising. You're giving less anesthesia. Anesthesia is neurotoxic. You're giving less neurotoxic drugs. The brain is reconfiguring its networks more efficiently. There is less postoperative delirium. Delirium is associated with other bad outcomes. Use brain monitors, have less delirium, improve patient outcomes. It is a very easy equation.
All right. And Dr. Agma, what do you say? Does BIS monitoring decrease postoperative delirium?
Of course, that's a very fashionable question. The reason that question has arisen is because the proponents, not finding a benefit with awareness, are now looking for other reasons to use their device. And the truth is, yes, there have been some randomized studies which have shown decreased delirium. I'm skeptical. Early positive trials are frequently not replicated, and the studies are confusing because some of them show higher dosing, some lower dosing. The mechanism is not clear to me, and studies which have compared the regional and general anesthesia don't show decreased delirium with regional anesthesia, so it makes no sense to me. Why should a slight decrease in the amount of anesthetic you give decrease delirium when we can't even show that the absence of general anesthesia results in decreased delirium? My prediction is that we will soon be exploding this myth.
Okay, Dr. Nair, Dr. Agma, I think our discussion here has highlighted some differences in opinions which may stem from the multitude of opposing results that are present in the literature. So my last question for you, why do some studies find improved outcomes with intraoperative brain monitoring while others do not?
Well, the easy answer is that a monitor in and of itself does nothing. You need practitioners who respond to the data provided by the monitor. I should say that the overwhelming majority of studies that have been done using bispectral index and other monitors have indeed shown improved outcomes. Some studies where either people have had an agenda, the studies have not been done properly, or people haven't responded appropriately to the information provided by the monitor have not shown improved outcomes. Other than that, when you use the monitor appropriately, you improve a whole range of outcomes, and I think that the majority of people would agree with that sentiment, apart from detractors like my colleague Dr. Agma.
All right, thank you. And Dr. Agma, a chance for your final response here. I'll ask you the same question. Why is it that some studies have found improved outcomes with brain monitoring and others have not?
Right, I think I alluded to this before. It's not surprising. Especially you've got a device, you can't blind practitioners, they know when they're using it. Many of the studies have been funded by the manufacturer of the device. They want to show improved outcomes. The largest effectiveness trials have often not shown benefit in any regard, and I think that the biggest explanation for this is a publication bias, people wanting to publish positive trials, conflicts of interest, people who are employed by the company or being paid by the company, but the trials that have been neutral often have not shown a benefit. And I think that what's necessary is rigorously conducted clinical trials, for example, for delirium and other outcomes, and these will be exploded in future. New generations of brain monitors based on neurobiology will hopefully be more compelling in showing better outcomes. Thank you, Christina.
All right, thank you very much. And thank you both, Dr. Renair and Dr. Agma, for all your comments here today. Some really interesting points for us to think about in terms of changing clinical practice and directing future research. So I look forward to hearing from both of you again and seeing if your opinions change in the future.
Yeah, thank you. Thanks, Dr. Renair.